Good morning. Welcome to the OHSU Effect Inside Health and Science. Today, we're going to talk about personalized cancer medicine in light of a phone bank hosted by the OHSU Night Cancer Institute and Coin TV. But before we get to that, we want to talk to Dr. Alan Sandler, a medical oncologist with the Night Cancer Institute and a nationally known lung cancer expert. Good morning.
Good morning.
What is personalized cancer medicine?
So it's a great question which has different meanings for different individuals. Specifically, the modern version of personalized cancer medicine refers to newer treatments that are directing themselves more and more specifically to a defect in the cancer itself that allows for a better kill rate of the cancer, if you will, and less side effects because it's hitting and targeting fewer non-cancer issues like bone marrow, for example.
Okay. Does every cancer center have personalized treatment?
So every cancer center is striving for personalized cancer treatment. There are varying degrees of success, but everybody is seeking that goal. I think what separates the Night from other centers is our ability to evaluate the tumor genetically and look for those specific, what we call mutations, defects in the DNA of the tumor to allow for that targeted therapy.
Okay, so describe how this personalized treatment is kind of changing how people are diagnosed and the way they are treated.
Okay, so what's unique now, it used to be that one would get a biopsy of a tumor. A pathologist would look at it under a microscope and determine that you had pancreatic cancer or you had lung cancer and maybe even told you a little bit about what we call the histology, what it looks like under the microscope. That technology is actually based on 17th century technology, the microscope. So we're advancing to an era where now individuals are looking at the actual molecular basis of the cancer, and that's where these targets attack. So cancers have different genetic makeup than the normal tissue. That's why they're cancer. And if you can find out which of those targets actually drives the tumor, then you have more and more success. Obviously, everyone's familiar with Brian Drucker's work with Gleevec and its effects in CML because he found that specific target that Gleevec worked on. And now an incurable malignancy is now literally a curable malignancy.
Is everyone's cancerous tumor, though, going to be different molecularly, or is it all the same?
Great question. So in general, there may be variants, but the tumor types, there may be different types of tumors. Let's just look at what I do for a living, which is lung cancer. We used to basically say, well, it's a small cell or it's a non-small cell. Again, how it looks under the microscope, which seems kind of embarrassingly simple nowadays, but that's the way it is. Now what we're doing is we're looking at the genetic makeup, and we're finding that more than 50% of the non-small cell types actually have unique genetic defects. We don't have treatments for every one of those, but that's totally different than what we thought before. And in general, there will be some similarities between, it's not that each individual, Fred has one and Mary has another. There will be some overlap. But one of the challenges of targeted therapy is you're now lung cancer, which had 200,000 cases annually, now you're breaking it down. 3% have this, 10% have that. So it's more challenging, but well worth the effort.
So how is it different from chemotherapy?
So dramatically different from chemotherapy. So chemotherapy, and this isn't to diminish the effects of chemotherapy, so those in the audience who may be on chemotherapy don't feel slighted. There are some definite positive effects from chemotherapy, but it's much broader because it's just targeting DNA in its most broadest aspect. And normal cells have DNA, abnormal cells have DNA, and the chemotherapy just targets the cells that are growing faster, which tend to be cancerous cells. As opposed to the targeted therapy where you're looking at more unique aspects of the tumor and hopefully sparing the normal tissue, so there's fewer side effects, less effects on bone marrow, low blood counts, infection, and then also, as important or more important, a better kill rate of the cancer itself, particularly if that target is involved in a pathway that's unique and necessary for the tumor.
So are targeted therapies available now, and are they available for all kinds of cancers or just certain ones?
They are available, and they've been available for some years. A classic would be Herceptin for breast cancer. I'm sure many of the folks in the audience know someone who's been on that, which dramatically changed what we used to call HER2, what we still call HER2 positive breast cancer, which was a very bad behaving cancer, but now with Herceptin has become much, much more treatable. Some aspects curable if it's early enough stage. Another drug called Tarceva, which is a drug, erlotinib is its generic name. Tarceva is the trade name for lung cancer for folks who have a genetic mutation that people can use and are being treated with now.
Are there other types of personalized treatment, in terms of surgery or radiation?
Yes, so, it's interesting if you ask what I often joke about when I'm speaking with audiences about targeted therapy, physicians or otherwise, is, surgery is a targeted therapy. I mean, the surgeon is going after a specific target, but, like removing the pancreas for pancreatic cancer. But we're trying to get a little more specific. Radiation, also targeted therapy, targets a specific aspect. And they have made tremendous advances, formerly just using generic X-rays to kind of target the tumor, now using 3 and even 4-dimensional aspects to target so that they're reducing toxicity. So yes, that's involved too. Another way to think about personalized therapy is also what we have are the nurse navigators, where patients are treated more on a personal level. This has nothing to do with treatment, but the concept of personalized care where every patient feels as if the whole group is working just for them.
Sure, they kind of have an advocate, if you will, in the hospital system.
Absolutely.
Got it. Well, let's talk about prevention. Are there any genetic tests to determine if a person is more at risk for a particular type of cancer?
There is. I think probably one of the more well-known ones would be the BRCA1 and 2, BRCA for breast cancer, found more prevalent in the Ashkenazi Jews. But where if that can be identified, then that family, for example, knows that they're at risk, and they can potentially take steps as to whether prophylactic mastectomy, what have you, screening is available for that population.
What about alternative medicine? How does that fit into personalized cancer care?
I think it can play a role, and there's no doubt that treatments such as acupuncture have actually passed the same rigorous testing that traditional medicine must pass in terms of clinical trials, showing that it does provide benefit, potentially reducing nausea with chemotherapy. Some of the other aspects of alternative medicine that are being used perhaps haven't been studied quite as well, but we're all interested in looking at those. And actually, the NIGHT it has some of those available, some of the alternative therapies available at the Center for Health and Healing.
So this sounds like a really exciting field with a really exciting future. What do you foresee?
So I think that I agree with you completely. That's really one of the reasons I'm in this. I think that there's lots of opportunity. I think the one thing that probably is not going to happen is one magic bullet for all cancers. I think we've all come to realize that. But step by step, we're going to start to impact more and more subsets of cancers in terms of improving life, living longer, improving the quality of life, and ultimately curing individuals of these cancers.
Well, I want to talk now about the phone bank hosted by the Knight Cancer Institute and Coin TV. That's on June 7th. And there's going to be doctors available to answer questions that people have about cancer, personalized cancer medicine. So what kind of questions do you hear most often?
Well, I think you've hit a lot of those questions, but I think what we would expect is there will be some personal stories, I imagine, and I think it's important to get the word out that we're here and we offer opportunities for patients to come and have either their tumors tested, second opinions, but they may want just some of the general information. Where are we headed? I think a lot of the questions may well relate to, am I, or is my family member, or is my friend a candidate for some personalized medicine? And we'll have those doctors, nurses, who are familiar with the studies that are available, so that they're to see just what sort of options are available for folks. And we often talk about if options are available other than the NIGHT somewhere that has something, we certainly would be willing to and able to discuss that as well.
Good. Well, Dr. Alan Sandler, a medical oncologist with the Knight Cancer Institute. His work is in lung cancer. Thank you so much for being here.
Thanks for having me.
More of the OHSU Effect Inside Health and Science coming up in 5 minutes.